Hello, everyone, and welcome to day 4 of the CCIH 2021 virtual conference. I'm Mona Bormett, Program Director at CCIH, and we are so glad you could join us for this time together. We look forward to being able, of course, to meet together in person again soon, but we are very grateful to have this technology to bring us together now. So you will see a slide on the screen with instructions in French and Spanish to join the language interpretation channels. So we hope that those who need the language options are able to utilize those. We will hold all questions until the end of the program today, which will be in approximately an hour and 40 minutes. Before we go into networking and breakout rooms. So we will collect questions until then. So please use your chat box to ask your questions. We will have staff monitoring that and making sure our moderator and speaker see that. And today I really want to say how grateful we are to our sponsors who have helped make this conference possible. Our gold sponsors today are the Eastern Mennonite University School of Graduate and Professional Studies, Health for All Nations, and the Christian Journal for Global Health. So EMU, Eastern Mennonite University, focuses on a collaborative online program where students have direct interaction with classmates and faculty. They are rooted in the Anabaptist Mennonite tradition of service, peacemaking, and community. And this program prepares students to be good stewards of available resources and lead with a dynamic healthcare system. Academic rigor and robust student support services provide the tools necessary for adult students to flourish. So thank you to EMU. And I'd also like to thank our joint sponsors, Health for All Nations and the Christian Journal for Global Health. Their mission is to engage the global Christian community in the exploration and application of biblical revelation, scientific evidence, and cumulative experience as they relate to health and wholeness. So CJGH is a peer-reviewed, scholarly, and multidisciplinary journal on global health policy and practice, promoting evidence-based and thoughtful analysis on approaches to global health from a Christian perspective. So we thank all of our sponsors. We're so glad you're here. Once again, if you need interpretation, it's located at the bottom of your screen. You can choose French or Spanish. And now I will turn it over to our moderator for today's session, Dr. Anbrasi Edward. Dr. Edward is a full-time faculty in the Department of International Health at Johns Hopkins University and is a member of the Center for Refugee and Disaster Studies at the Center for Global Health. She has led health systems and community-based research and project evaluations as principal and co-principal investigator and provided technical support to several organizations, including the World Bank, World Relief, World Vision, and many more. Mentoring and supporting students who have a passion for serving disadvantaged populations in the US or globally, especially those who serve or support Christian mission organizations who have extreme resource constraints, has been a major practice goal of Anbrasi. Anbrasi has served in the past on the board of CCIH, which is how I met her so long ago when I first started at CCIH 10 years ago. And Anbrasi has also graciously led pre-conference sessions on monitoring, evaluation, and learning for CCIH. She's been a huge supporter of this topic in this organization. So welcome, Anbrasi. We're so glad you're here. Thank you for your willingness to take us through our learning today. So over to Anbrasi.
Thanks very much, Mona. Welcome to everybody. If you are new to CCIH, we are an international network of nearly 120 Christian organizations and 15 secular partners, as well as a few hundred individual members, most of whom are based outside the US. CCIH's mission is to promote health and wholeness from a Christian perspective, and we provide opportunities for capacity building, networking, sharing best practices, and advocacy. This session is being recorded and will be posted on the CCIH YouTube channel in a conference playlist, and you can find the links to the recordings on the CCIH website at www.ccih.org under Events. With the advent of the Sustainability Development Goals and universal health coverage, we have rapidly advanced from the traditional monitoring and evaluation models to collaborative and continuous learning paradigms, transforming the accountability landscape with new dimensions, guiding principles, the engagement of civil society and people-centric systems, ensuring accountability, relevance, and resilience across contexts. Yet there are inherent flaws in our statistical models, and therefore the quest for exploring the unexplained variance in our traditional metrics. We often quote Lord Kelvin, "You cannot manage what you cannot measure," but Albert Einstein reflected that not everything that can be counted counts, and not everything that counts can be counted. This morning, we have an interesting and exciting lineup of experts who have spent many decades in the trenches, battling the maladies of healthcare systems and designing performance metrics. They have been powerful influencers in transforming the innovation paradigm through their contributions and the confluence, particularly of faith and health outcomes. Our first speaker today is Dr. Harold Koenig, and he is going to be talking about how Christian faith influences health outcomes and how faith changes through the engagement of Christian services. This is a pre-recorded talk, and Dr. Koenig is the director of the Center of Spirituality, Theology and Health at the Duke University Medical Center, and an expert on positive influence of religious involvement in public health. He has published extensively in over 500 peer-reviewed articles, 100 book chapters, and more than 50 books. His research has been featured on national and international TV and radio programs and newspapers. He has also given testimonies before the US Senate and US House of Representatives on the benefits of religious involvement on public health. The recording is a brief excerpt of a longer session, which will be available online at the CCIH website. And this will include resources on different scales and assessment methods as well. The excerpts that we are providing today explain key principles and summarize several concrete examples. And we apologize for any incoherence or technology issues that were caused with the tempering of the recording, and encourage you to listen to the entire recording at a later time. Over now to Dr. Koenig.
Hello, I'm Dr. Harold Koenig, and I'm going to speak to you a little bit about spiritual metrics. Next slide. So kind of in summary, first of all, I will talk about categories of measurement, then provide a definition for terms like religion and spirituality, since I see from the title here that this involves spiritual metrics. Talk about some of the dimensions of religion and religiousness. Look at some of the actual measures that are used in research, and then talk about some of the measures that are used in clinical practice. And then finally, look at how to measure the faith-based influence. Next slide. So definitions are really important, but in today's world, they have become very confusing. Religiosity involves beliefs, practices, and rituals related to the transcendent, where the transcendent is God in Western traditions. It may involve beliefs about spirits, angels, demons. Usually, religion involves beliefs about life after death and provides rules to guide behaviors in this life. Religion is often organized and practiced within a community, but it can also be practiced alone and in private outside of an institution, such as praying or reading one's religious scriptures, these private kinds of activities. So religion, many people interpret religion as institutional religion, whereas it can be conceived much more broadly in terms of both institutional kinds of practices, like attending religious services and being involved in other community-oriented religious gatherings, and also private activities, like I said earlier, such as praying, reading religious scriptures, or watching television, or listening to religious music. Now, spirituality has become largely divorced from religion within the current culture. Previously, the traditional understanding of spirituality was that it involves a subset of religious people who were deeply religious, whose lives surrounded around their religious faith, that this was central to their lives, their religious beliefs. And these individuals were called spiritual. But that has all changed within the last, only within the last 20 or 30 years, such that spirituality has now become at times divorced entirely from religion, such that you can be spiritual but not religious. You can be spiritual in however you want to be. You define it yourself. And there are no restrictions, there are no responsibilities. It's basically whatever you want it to be. And a lot of times it just kicks God out of it, so that it's a humanistic kind of spirituality. And so this becomes very popular within science, within the mental and physical health sciences, to boot God out of it. Nobody wants God in it. So they call it spiritual, whatever that means. It's different for every person. So today, spirituality is considered personal, something individuals define for themselves. One can be spiritual but not religious. Spirituality, therefore, is seen as non-divisive, common to all, both religious and secular. The term spirituality is especially useful, however, in clinical settings. Because of its vague and nebulous nature, though, it's very difficult to measure and quantify. And really, no one has done a great job of measuring and quantifying spirituality, although we'll take a look at a couple of measures. Next slide. So here are the various dimensions of religion, and only a few of these have to do with organized religious activity. There's religious denomination or affiliation. There's religious belief or orthodoxy of belief. There's public religious practices like attending religious services. There's private religious practices such as prayer or scripture reading. There's subjective religiousness that is sometimes called importance of religion in life. There's religious motivation or religious commitment. And we'll look at some of these measures in a moment. There's also religious well-being, the well-being in one's relationship with God. There's religious coping, both general religious coping practices as people try to deal with stress and loss and these kinds of things. And there's very specific religious coping practices that are specific to certain situations, such as those that Ken Pargament developed. There's also religious history. Religious history involves how religiously involved people have been in the past, during childhood, during early adulthood, during their middle adulthood, religious history. There's also religious support that one experiences from one's faith community, both positive support and negative kinds of interactions. So there are measures that assess that positive support, both received and given, as well as negative interactions within church settings. There is religious experience, love of God, for example, or mystical experiences. There's religious giving in terms of giving money or volunteering one's time for religious causes. There's religious knowledge. How much does one know about one's scripture in terms of details of, the Bible or whatever? There's religious growth. To what extent is a person growing in their religious faith? And then there's measures of, or there's a dimension of religious maturity that has to do with how mature one's religious faith is. Now, all of these dimensions are measurable, and there are instruments out there to do that, to quantify each of these dimensions. Next slide. So here are examples of commonly used scales. Now, this is the belief into action scale. So we've got Arabic, Persian, Chinese, and Spanish versions of this scale. Next slide. So the first question is, please circle the highest priority in your life now, the most valued or prized. So the options are then my health and independence, my family, my relationship, my friendships, job, career, business, my education, financial security, relationship with God, ability to travel and see the world, listening to music and partying, freedom to live as I choose. So 10 very important areas. If a person circles anything other than number 7, they get a 1 on this scale. If they circle 7, they get a 10. So even if you put family, if you circle family, you get a 1. You only get a 10 if you circle relationship with God. Next, how often do you attend religious services? Ranging from never to daily. Other than religious services, how often do you get together with others for religious reasons? Never, all the way up to daily. To what extent have you decided to place your life under God's direction? Not at all, to completely or totally. What percentage of your gross annual income do you give to your religious institution or to other religious causes each year? From 0 to 15% or more. Next slide. On average, how much time each day do you spend listening to religious music or radio or watching religious television? On average, how much time each day do you spend reading religious scriptures, books, or other religious literature? On average, how much time each day do you spend in private prayer or meditation? On average, how much time each day do you spend as a volunteer in your religious community or to help others for religious reasons? And then finally, to what extent have you decided to conform your life to the teachings of your religious faith? Next slide. Here's the Duke Religion Index. So there are the 5 items. First is the attendance. Next are the private religious activities, and then the intrinsic items from the intrinsic religiosity scale. So basically, we have compared the Durrell with the BIAC, and the BIAC is about 80% more sensitive to detecting relationships with mental health outcomes. And that's why we've been just continually recommending the BIAC to assess for the degree of religious commitment. It ranges from 10 to 100 points, and the average score is around 50. Next slide. Here's the spiritual well-being subscale. This is a valid subscale for measuring religious well-being. You can see those items there. I believe that God is concerned about my problems. I believe that God loves me and cares about me. And then there are some, I don't find much satisfaction in private prayer with God. So that's scored in reverse. Or I don't have a personally satisfying relationship with God. That's scored in reverse. And then, I feel most fulfilled when I'm in close communion with God. My relationship with God contributes to my sense of well-being. So that's the religious well-being subscale. Next slide. So in summary, understand two types of measurement. One measurement type is for research purposes. The other is for clinical purposes. Understand the differences between religiosity and spirituality. Be aware of the different dimensions of religiosity. Understand the strengths and weaknesses of each scale, their lengths, and how commonly they are used. Before choosing a scale, be aware of the items that make up the scale and whether they are capturing what you want to measure. That's probably the most important conclusion here, is that one. Decide on what you want to measure, religiosity or spiritual outcomes or mental health outcomes, and keep them separate. Thank you very much.
Thanks very much, Dr. Koenig. I'm convinced that his talk has ignited many of us to consider spirituality and faith in our outcomes research paradigms. The belief into action scale and other validated scales may be a place to start. It looks like we have an overwhelming evidence that demands a verdict for future considerations. The National Institute of Public Health, Institute of Medicine, has published over 72,000 peer-reviewed articles just on prayer and 113 publications on intercessory prayer. So it's something that we have to closely consider in our performance paradigms and measurement and evaluation frameworks. Another reminder to look out for the full recording on the conference website. Now I would like to introduce our next speaker, Mary Lindloff. She is the Senior Director of Analytics and US Programs at Kingdom Workers. She provides oversight to the US programming, and this includes monitoring, evaluation, and learning for all Kingdom Workers, diverse programs globally, and analytics across the organization. Her background is in research, analytics, and strategy, and she is always striving to help organizations optimize their impact through data insights. So over to you, Mary Lindloff.
Hi, everyone. Thanks so much for the opportunity to speak. Before I dive into talking about 5 tips for spiritual impact, I just wanted to give you a little background about my organization in case you aren't yet familiar with Kingdom Workers. So I work for Kingdom Workers. Like many organizations, we seek to help people both physically and spiritually. We work around the world in many different locations with many different programs. We mobilize local volunteers to do things like provide therapy to children with disabilities, help build and maintain water solutions, and a lot more. Our programs are very diverse, but one key component of everything we do is to help people spiritually. It's often easy for people to agree that we should measure physical health outcomes. Organizations readily measure changes in things like breastfeeding, nutrition, stunting, hand washing frequency, and more. However, many organizations do not yet measure spiritual impact. I'd love to give you 5 tips for how to measure spiritual impact. I'd love to encourage you to start measuring them, or if you already measure them, help you to get even better at it. Next slide. Tip number 1, don't be afraid to measure it. As we heard in the prior presentation, it can get a bit difficult. But we want to help people spiritually. Many of us belong to organizations that have a mission that includes that spiritual impact, along with the physical health impact. We can better help people when we know the impact that we are making in their lives. If we don't know how we're impacting them, it's hard to improve what we're doing. Therefore, we measure impact, and I'd encourage you to do the same. Don't just measure the physical, also measure the spiritual impact. Now, I also want to say that spiritual impact gets a little complicated. Depending on your specific religious beliefs, you might view God as the person who changes people spiritually, not us individually. I encourage you to always view your spiritual impact and your spiritual measures in the light of your religious beliefs. Just because we measure it doesn't mean that we're taking all the credit for the change. We're simply measuring it and viewing it in the context of our worldview. The next question is, how do we actually measure it? Next slide. So my second tip that I have is to develop specific spiritual outcomes. And you saw this a bit in the prior presentation where he referenced some of the ways in which you can get really specific about what exactly you're measuring. So I'd encourage you to avoid generic outcomes like spiritual growth or learn more about God. Get more specific. What exactly are you trying to change in someone's life? Some examples are as follows: more people knowing that Jesus died for their sins, people sharing their faith with others more often. There are countless potential spiritual outcomes. The key is to pick specific outcomes and focus on those. Leaving the outcomes too vague won't be very helpful for you. To give an example related to physical health outcomes, we rarely have health outcomes like improve health. That's hard to measure. We have health outcomes such as increasing hand washing, decreasing waterborne disease, and more. This principle applies to all outcomes, both physical and spiritual. Being more specific is going to be a lot more helpful for you. Next slide. Tip number 3 is to ask about knowledge, feelings, and behavior. Oftentimes when people start thinking about spiritual metrics, they think of measures of knowledge and feelings. How close do you feel to God? It's good and important to ask about knowledge and feelings. One example that we often ask at Kingdom Workers, because it's important to what we do, is how familiar are you with the gospel message that Jesus died and rose to take away your sins? This is helpful for us to know if there is that initial knowledge change. However, we also ask about behavior change, and I'd encourage you to as well. One example is asking people, have you been baptized? You can see in the visual on the right that we regularly assess baptisms as part of our evaluation of a disability program in Malawi. In 2017, 62% of the children we served had been baptized. This increased to 77% 2 years later, indicating that more children had been baptized. You can also ask if people pray, if they share their faith with others, and so much more. The key here is to choose the outcomes that best fit with what you are trying to do as an organization and what your objectives are. When looking at physical health outcomes, we often ask about knowledge and behavior. One example would be asking people if they know how to store water properly, and also observing if they're actually storing the water properly. In the same way, we can focus on asking questions about both knowledge and behavior when asking spiritual questions as well. Next slide. Tip number 4, this might seem obvious, but it's often overlooked. Recognize cultural differences in spirituality. The way people express their faith often greatly differs across cultures. The way that people in Malawi show that they are Christians is often very different from how people in Japan show that they are Christian. There are many factors at play here: cultural and traditional norms, government regulations, and much more. How do you recognize and account for these differences? The best way you can do this is to make sure that you are really engaged with the local people and experts in that culture. Don't assume that you can measure spirituality in the same way across every location. Talk to your experts there and test different questions. Be in touch with the nuances of that specific location. Next slide. Tip number 5. This is probably one of my favorite tips, which is connect with other organizations to learn more. This has been one of the best things I've done to keep learning and learning from others in this area. reach out to people and ask them how they are currently measuring spiritual impact. You can learn and improve a lot faster this way. I'm part of a roundtable of organizations that's led by IDO Research. IDO Research is working to develop a robust measure of spiritual impact. We're all working together to help do this. I've also found amazing people to connect with through conferences just like this. Also, simple searches on LinkedIn have connected me personally with many people. Just setting up one-on-one phone calls with them, learning what their organizations are doing, and how we can learn from one another. Definitely consider doing this to further guide and refine your approach to measuring spiritual impact. Next slide. Thank you for your time. I hope you have found this encouraging and has encouraged you to start measuring spiritual impact, or if you're already measuring it, I hope I've given you some tips that you can directly apply to your evaluation work. I'd love to connect with you on LinkedIn, or feel free to send me an email. I'm always happy to talk. Thank you.
Thanks very much, Mary. That was very inspiring. As kingdom workers, we all have the analytics arsenal now to illustrate the faith evidence in our global engagements. Mary's made a compelling case and given us a clarion call as faith workers to measure spiritual impact. And I, for one, am looking forward to integrating these metrics in the work that we do across nations. Our next speaker is Dr. Jennifer Philippa Eggert. Dr. Eggert is a Senior Research Associate at the Joint Learning Initiative on Faith and Local Communities. She has close to 20 years of experience in research, practice, and policy in Europe, the Middle East, South Asia, and the US. She's worked for universities, research institutes, NGOs, various think tanks, development organizations, and international organizations as well. Her areas of expertise include gender, development, faith, political violence, preventing violence, extremism, and migration. She publishes regularly in academic and policy and practice focused papers, and is the author of the recently published JLI Compendium on Monitoring, Evaluation, Accountability, Learning, and Faith. Over to you, Dr. Eggert.
Okay, thank you, Anbrasi. And hi, everyone. It's really good to be here. I will be speaking about monitoring, evaluation, accountability, and learning as it intersects with faith. And I will be asking if we could or should go beyond Western approaches. Next slide, please. So I have prepared a introduction and welcome slide. I will skip the part on the left-hand side because Anbrasi has already covered that. So I just say a few words about my organization, the Joint Learning Initiative on Faith and Local Communities, or JLI for short. JLI is an international collaboration of organizations that work on the role of faith actors in development, humanitarian action, and peace building. We focus on shared learning and research. Next slide, please. The JLI mostly works around learning hubs. We have around 5 or 6 learning hubs at the moment that all bring together representatives of faith-based and secular organizations who all work on a specific topic as it relates to faith and the role of faith actors. And one of these is the Meal Learning Hub. The purpose of the hub is to share learning and produce research and disseminate research with a focus on meal as and with faith actors, doing meal as and with faith actors in the context of development, humanitarian action, and peace building. The Meal Hub was set up in the autumn of 2019. It has around 20 members at the moment, and the compendium that Anbrasi mentioned in her introduction, a compendium of good practices in meal in partnerships between international actors, either secular or faith-based on the one side, and local faith actors on the other, was published earlier this year. Next slide, please. So let me tell you a little more about the compendium, and let me tell you a little bit more about the research that led to the publication of the compendium. So we first issued a call for case study submissions, received a couple case study submissions on how different actors in the field do meal in partnerships between local faith actors and international actors. We received a couple of submissions, but most of them were from Christian and Western context. And we wanted to go a bit beyond that. We wanted to be a bit more diverse. So we decided to dig deeper and reached out to around 90 stakeholders and ended up doing 30 in-depth interviews. The focus of these interviews was really on the challenges and opportunities of organizations in the field. And we then decided to divide the compendium into 3 sections. We have a first section where we discuss challenges and opportunities for organizations that want to do meal with local faith actors or as local faith actors. That's the first section. Second section then highlights the experiences of 10 organizations from different faith backgrounds and across the globe, showcases the diversity of approaches in the field. And then the third section contains resources that we were hoping would be useful for organizations in the sector that are thinking about how to do meal with local faith actors. Next slide, please. And then what emerged pretty fairly early, and I've already alluded to that, was there was a strong dominance of Christian and Western approaches. And this is not something that was new to us. We know from our previous work that Christian and Western approaches often dominate in international fora on questions of faith and development. So we asked why is that the case, and we specifically reached out to non-Christian and non-Western actors in the field. And it turned out that barriers to meal, there tend to be 3. The first one is a lack of capacity and resources, which makes organizations prioritize other areas. So programming, for example, sometimes advocacy a little bit, but mostly programming. The second is a reliance on community funding. So it was really interesting to see that a lot of the Islamic organizations that we spoke with, but also Hindu and Buddhist organizations, they didn't get their funding from institutional donors, but from individual donations from their communities. And the relationship there was much more based on trust rather than formal meal requirements. And then lastly, there were faith reasons and just a different approach to data and accountability. And what was really interesting in this context was some of the Buddhist approaches to learning and accountability. So when I first contacted some of these organizations and I asked them about meal, they said, meal, Jennifer, what are you talking about? What is meal? We don't do meal. We don't need meal. We're not interested in meal. But then when I continued to ask questions and we continued the conversation, it actually turned out that they have developed other forms of sharing learning and of evaluating their activities that stem from their faith tradition that they would never call meal, that a meal expert would never call meal, but they actually fulfill the same function. Next slide, please. So that's something that we found really interesting. I was asked to give you 3 takeaway points. I don't really like you to tell what to think. So I thought I'd give you 3 takeaway questions instead. And these go from simple to more complex. The first one would always be to ask if our meal practices are appropriate for work within as local faith actors. And I think some of the other speakers have mentioned a lot in this area already. A second question then needs to be, what are barriers for different faith actors working in different contexts to actually integrate meal into their activities? And then lastly, do we allow space for approaches that are alternative to us? And it may actually seem to contradict, reject, or ignore Western notions of meal. And it's me out and over. Thanks.
Thanks very much, Jennifer, for a riveting talk on integrating the faith metric for meal and the important compendium. I'm particularly impressed with the diversity and inclusion objective of considering case studies and metrics from Asia and Africa and Latin America and overseas, and not just, the classic publications and resources that we get from the high-income economies. I'm sure this will be a valuable reference and resource for those of us considering appropriate metrics to measure the impact and to look at case studies and modeling this work within our organizations. Our next panel of speakers will focus on the community engagement element in learning systems. And we begin with Naomi Macau, and she is the Program and M&E Manager for World Renew, Kenya, and has a background in demography and development studies. Ms. Macau has extensive experience in project design, management, and evaluation of health, agriculture, livelihoods, and disaster response projects. She is also skilled in routine monitoring and accountability and learning indicators and tools development, staff capacity building, research, reporting, and documentation, as well as using statistical packages for analysis. She is very passionate about building community capacity that leads to empowerment and transformation through the use of information for strategic decision making. So over to you, Naomi.
Thank you very much. So today I would like to share with us about simple processes that we are currently implementing in Kenya through our partners here in Kenya. As mentioned earlier, I currently work for World Renew, and we realize the importance of monitoring and evaluation generally on strategic information. But again, we do realize that there's been so much concentration on the scientific and technical bits of it, where we feel like there's a lot of gain when we make them simple and when we allow the community and community systems and structures to be part of this system to allow for impact, a larger impact, and more sustainability. Next slide. So the project that I will be discussing today is on MNCH, on maternal health, and it is a current project. It is ongoing, started in 2019, targeting pregnant women, lactating mothers, women of reproductive age, and children under 2. This project is very exciting for us because it's a project that we have decided to take the route of simplicity in the area of monitoring and evaluation. And why I say simplicity is because we have chosen to do a lot of participation in this aspect of strategic information together with the community members and together with the community, the health structures that are already existing in the community. So we are using the community health strategy that works with community health volunteers who are selected and trained on topical issues by the government and are available to, to do outreach in the areas of health. And so these are the main contacts that we have with the community members in this particular project. In this project, we have designed very simple tools that these health workers who are not necessarily literate are able to use, implement, collect data, be able to do very simple analysis and draw out information that is important to be able to make crucial decisions for the project. Next slide. So these are some of the very simple tools that we have designed for this project that basically just collect simple information from all beneficiaries. And much of this information is collected through checking a box or answering whether an activity is done or not, and it's divided based on all the activities that we do. And from our experience, regardless of the literacy level, a community health worker is able to utilize this particular tool. Next slide. This slide also is a slide that shows a tool for aggregation of the data that we collect. And from our experience as well, we realize that it aggregates the data, but also allows for very simple and basic analysis to be done that doesn't necessarily need any technical capacity from World Renew or from our partners, but that can be also utilized even in the absence of World Renew and in the absence of our partners, where community members and the community health volunteers are able to collect this information, they're able to aggregate it and be able to still draw information out of this basic tool. Next slide. So generally, this is the process that we go through in regards to data collection all the way to analysis and utilization for decision making. So this community health volunteers will collect data with the tools that we have seen in the previous slides. They'll be able to collect it and do very basic analysis that allows for them to write reports and allows for them to be able to draw knowledge and learning that would influence the activities and ongoing tracking of the project. The next bit of that process shows where there is the community health volunteers together with the partner staff and together with World Renew are able to sit down and review what information is coming from the reports and from the data that is being collected. But at the same time, they're able to also report through the government of Kenya Health Ministry, where tools are provided. They're able to report through those tools and are able to say the same thing in regards to different indicators. They're able to showcase what the data is saying in regards to the projects and the interventions that they are implementing. But additionally, this also offers an opportunity and a platform to interpret and validate and say that, yes, this is what we are seeing and this is what is actually happening. The next process is a feedback process where these community health workers are able to give a feedback to the health facilities through the health extension workers and to the local administration through the village elders, through the chiefs, through generally everyone who's at a local administrative position, and that they're able to tell this these structures, what the reports are saying, what the gaps are saying, and allow for them to make decisions around what the data is saying. And the last bit is where we are seeing the decision-making process and action is informed by what is being drawn out of the reports. Next slide, please. So the question that we are asking here is whether we have seen any change process that has begun to, whether we have already begun to note any change process based on doing monitoring and evaluation processes through the community structures. We have not yet been able to do a midterm assessment, of course, because of our current situation, but from the routine data, we are already seeing some very key and fundamental preliminary results. For example, in regards to the uptake of exclusive breastfeeding, we are seeing from the data that many women are currently taking up breastfeeding, and this is because the community members and the village elders and the facilities are able to influence the same through certain structures. We are seeing that more community members and households are able to agree to have, say, latrines, garbage pits where they didn't have before because of what is coming out. Next slide, please. So these are just general sharings from what we are hearing, not from the project and not from project experts, but generally from the community, what the community is able to say about the data and what the community is able to say about the project implementation and the impact that it's causing. The first person is a community member who is saying that they have seen change that is influenced by the data because of the process of ownership, where they're able to own that data and be able to implement change based on the results that are coming from the data. Next slide. This is just a picture that generally shows that the community members, together with the village elders, together with the health facility workers, are cleaning water because the data showed that the water that they're currently using is not good for drinking, and so they're all coming up with solutions on how they can make it better. Next slide. And this again is a slide that says that a village elder who's in charge of generally the village is saying that now they are able to influence the community members to be able to make decisions or to be able to cause changes based on the results that they're seeing from the data. So where they were not having latrines, the community elder, who's not necessarily a health expert, is able to influence the community members to take up some of these changes so that they are able to have more latrines to improve on their sanitation and hygiene. The last slide. So this last slide generally is from a health facility supervisor who's assuring the project that from the results that are coming out, they are also, they're also modeling and planning around what is being stated. They're able to say that there is an increase in hospital deliveries because there was timed and targeted counseling that was done by members of the community who are the health volunteers, and that influences the changes that the community members have in regards to where they deliver. So generally, this case was just to show us that much as monitoring and evaluation has for a long time been seen as a technical area that community members or community structures may not be helpful in, we are coming in with this case to say that it is important to include and involve the community members and community health structures in this process, because first, it assures of sustainability, but at the same time, it allows for ownership and continuity even after the project has come to an end. Thank you.
Thanks very much, Naomi, for another inspiring talk on your work with community health volunteers, especially in Kilifi. The importance of engaging the national ministries of health, I found, was very critical to influence future policies and measurement constructs. And I was particularly impressed with the empowerment of frontline providers with the participatory data collection modality to ensure a sustainable value-based system. As we progress toward universal health coverage and no one left behind, which comes from the biblical perspective and parable of the lost sheep, your work is very critical to think about to address an empowerment modality for community health worker systems, as well as households to be co-producers. Thank you very much. We now move on to James Banda, who is at World Relief Kenya. He is the project manager for strengthening community health outcomes through positive engagement project. And this is funded by USAID through the NPI mechanism, which is a multi-country endeavor in Haiti, Kenya, Malawi, and South Africa. Mr. Wanda has over 15 years of experience working in healthcare and health project management. Before joining World Relief, he worked at the Kenya Pediatric Association's Pediatric Fellowship Program. He's also worked at Amref Health Africa with Japaigo in Kenya and also CMMD. He is a trained nurse by qualification and currently working towards a master's in public health. Over to you, Mr. Wanda.
Thank you very much. Good morning, good afternoon, good evening, wherever we are. I'd like to take the next few minutes to take us through some of the few things we've learned out of local partnership as we implement a project called SCOPE. Next slide, please. Yeah, so SCOPE is an acronym that means strengthening community health outcomes through positive engagements. And it's a 5-year USAID funded project in 4 countries, Kenya being one of them. The goal of SCOPE project is reduction of preventable maternal and child morbidity and mortality. Next slide, please. Yeah, so in SCOPE project, we have key resource areas and mechanisms of delivery, which I'll try to explain in this slide. We have 4 key resource areas, one of them being to increase access and utilization of reproductive, maternal, newborn, and child health services, RMNCH. The second resource area is to enhance the quality of those services. Key resource area number 3 is improved health, seeking behavior among the community that we serve. And the last one, which is the 4th, is strengthening the two-way community facility linkages. Our delivery mechanisms is that we work through community health workers, and here we have 2 cadres in Kenya. We have community health volunteers who are non-professional community members, and we have community health assistants who are government employed. They are professionals trained in community health. We also work through faith actors across the divide of religions, and we have also worked through several community groups, such as care groups, savings groups, men's and couples groups. And all these approaches are founded on the social accountability monitoring SAMS concept that is being implemented under the community health strategy in Kenya. Next slide, please. Yeah, so this slide basically shows where we are in Kenya. We are in 2 counties, as you can see from the map. The one to the northwest is Turkana, and to the south is Kajiado, working in 2 sub-counties in each of those counties. Kenya has a devolved mechanism of governance, which is county system. So a county will be a region within the country. We have a total of 45 linked health facilities that we work with. To date, we are working with a total of 394 community health volunteers. Over 1,000 care groups have been formed, which are mediums for messaging to women of reproductive ages in those communities we serve. We have a total of 6,200 care group volunteers who are actually members of those care groups. And we work with 45 community health assistants who are actually attached to those 45 linked facilities. In terms of the faith spectrum, we working with 300 churches in the 2 counties, 7 mosques, and these faith institutions are organized into what we call faith network committees, which are basically arrangements for the number of faith institutions that are found within a local geography for their administrative and operational purposes. We collaborate with the county governments and the National Ministry of Health, and we even have a memorandum of agreement with those 2 counties. In terms of reporting and recording, we use the Ministry of Health mechanisms, which is the community-based HMIS, Health Management Information System. Next slide, please. Yeah, so here is the structure of the partnership within SCOPE. World Relief, being the prime in this project, is working with CHAK, Christian Health Association of Kenya, who are, in this case, a local sub-award, and their role is to implement RMNCH services through complementary facilities. And so in so doing, CHAK actually expands and deepens the reach of SCOPE project. But we have Christian Connections for International Health, CCIH, who are playing a role of pass-through grant mechanism for SCOPE sub-awardees in all the 4 countries. And in so doing, you have World Relief, CCIH, and CHAK working together to implement SCOPE project. But this is a partnership that's specific to this project, but wherever we're working, we have several other implementing partners who are tasked with RMNCH projects. And so we have interlinking mechanisms with them, and the overall coordination and policy management is done by the Ministry of Health in the country. Next slide, please. Yeah, so I'll share a few of the successes so far we have through SCOPE project. We have technical support from the technical team of World Relief HQ, which ensures that we have technical integrity for our programming and fidelity to the program design. We've also managed to secure buy-in and support from Ministry of Health, both at the national and the 2 county levels. We are implementing co-planning and bi-weekly progress update meetings with CCIH, World Relief, and CHAK. And as I had already mentioned, we have memoranda of agreements between World Relief and the 2 county governments of Turkana and Kajiado. This also has seen us regularly and timely share activity or work plans with the concerned players in the project. Next slide, please. Yeah, in the course of implementing our project for the 2 years now, we've met a few challenges. One of them being that in the course of implementation, there is a change of expectation, which leads to, during the implementation, we have a change of expectation from the County Health Management Team, CHMT. We've also had delayed approvals of work plans. We work in such a way that we have a 2-layered approval from our donor USAID, both from the Washington and the local mission in Kenya. COVID has impacted us negatively in 2 ways, in such that we've had travel restrictions and activity restrictions, but also it becomes a competing task for the county teams, who sometimes are stretched wide and thin so they can't focus on the project scope or project work. But we've overcome this through development and signing of memorandum of agreement with the counties to harmonize the operations of scope project. We've also had to reschedule some activities to mutually agreeable dates. Where applicable, we have used virtual platforms to ensure that these activities don't stall. And of course, we've learned that sharing project plans early enough with the counties so that they can be prioritized as they plan for their activities. Next slide, please. Yeah, so we've learned some lessons which we would like to share with other implementing partners. One of them is that we cannot do away with joint planning and prioritization. It is important as it gives all stakeholders a chance of having a common understanding of the activities to ensure the success of such activities. Before the start of the project, it's important to have pre-implementation consultations with all players in the project to ensure common understanding and shared vision. It's important also to factor in our projects contingency measures for any eventualities such as COVID, and also that we've learned that the Ministry of Health and all the other players in RMNCH program are gatekeepers of success, and appropriate sharing of the project deliverables and priority areas is good to ensure that there is synergy in project implementation. So these are some of the lessons that we've learned in the 2 years of implementing SCOPE project, which we'll be willing to share with anyone else who are willing to come on board to implement RMNCH through local partnerships at the community level. Thank you very much.
Thanks very much, Mr. Wonder, for another very inspiring talk on your field experience with the SCOPE projects. The distinctive feature of this framework is the extensive network and engagement of churches and the faith network as an aspect that is often neglected and overlooked in our development engagements. We discovered with the Ebola epidemic that the engagement of pastors and other religious leaders is a key driver to the management of disease, and we need to look at the trust aspect that they bring on and the importance of the spiritual investments that they make to enhance and improve the investments that are made by development communities. You've provided us a very critical framework for future consideration, and we are looking forward to learning more. Our next speaker is Matitha, and she has over 20 years of experience in maternal and child health, integrated nutrition and livelihoods programming in Malawi. Prior to joining World Relief Malawi in 2017, she worked with Save the Children, the Catholic Relief Services, and Mary's Meals. She has a BA in Humanities with a major in nutrition and is currently studying for her MPH at Share World University in Malawi. She has also been newly appointed as the country director for World Relief in Malawi. So over to you, Matitha.
Hello, everyone. I'm going to share with you the partnering with governments at the community level as a continuous learning to success and sustainability of health systems. Next slide. Okay, World Relief is implementing a scaling up nutrition project starting from 2017 to 2022. The project is in 4 districts of Malawi, and it's covering over 2,000 households with pregnant women, lactating women, and children under the age of 5. It's a multi-sectoral project, and uses an integrated nutrition programming. Care groups are a strategy which is being used, but then in this project, World Relief is integrating care groups into the government of Malawi structure, and the program is being implemented at scale. Next. Some of the results since we started implementing this project, we've seen increase in some infant and young child feeding indicators. For instance, we've seen increase in early introduction to breastfeeding in the Lilongwe and Dowa districts, and we've also seen increase in exclusive breastfeeding as indicated in the figure. Next. We have also seen from baseline to midline an increase in children receiving zinc and ORS for diarrheal treatment. Next. In this diagram, we are seeing the integrated diagram, which is used the integrated approach where the care group has been integrated into the government of Malawi structure. Below the diagram, we can see that 8 to 12 households are assigned a volunteer, and these volunteers form what we call a care group. And then these care groups are assigned to a group of frontline workers, which are called the Village Nutrition Coordinating Committee. And the Village Coordinating Committee reports to the Area Nutrition Coordinating Committee, which reports to the districts and at national level. This is the structure which is being used in Malawi for both capacity building, for reporting, and for feedback. So it comes to capacity building, you are going to use the Village Nutrition Committee or the Area Nutrition Committee, and at district level, the same thing, the DNCC is used at national level. And also in this structure, we see that there are community leaders called clans and clans, which are also part of the system, and they help in advocacy for health and nutrition issues. Next. Okay, as indicated earlier on that the diagram that we saw earlier on, learning is happening at all levels. It's not just at national or district level, but even at TA, and this is sub-district, and also at village level. Next. So the avenues for learning in this project include review meetings, and these review meetings happen at all levels as indicated earlier on. For example, at sub-district level, which is a TA level, there are local rapid assessments that happen every 3 months, and also we have data from quarterly reports. So all this information, when the different stakeholders meet at sub-tier level, they will look at this data and analyze it and understand what are the successes, what are the gaps, and what are the challenges. And at that level, the sub-district, they will come up with micro plans that will help them address the challenges. And these micro plans are shared with the community leaders and also the volunteers, so that together they come up with a joint plan and say, what is it that we are going to do to address the current gaps? And these micro plans are also shared at district level. In case there's need for resources, these micro plans are supported or funded by different civil societies or even the government to implement it. I'll give an example. In one of the communities, they had a challenge for water to water the backyard gardens. And through this process, they were able to identify the problem and link their community to potential partners who were able to bring water in the community. Next. And at national level, the same thing is happening. We have what we call the Sun Learning Forum. The Sun Learning Forum, they are government officials, donors, and even some officers from the districts. They come together and they also look at the data, which normally comes from the communities. And at national level, they will look at this data and look at what are the gaps. An example, like in Malawi, we had our nutrition policy was not addressing nutrition adolescent nutrition. But with the coming of this approach in the Sun Learning Forum, they were able to identify that it's important to also look at, if we are to deal with the maternal nutrition, it's also important to look at adolescent nutrition. And the policy has been revised, and strategies and interventions have been put in place as a result of these learning forums. Next. One of the challenges that we are facing is that it's difficult to engage at community level. And to address this one, we are bringing in new tools, the scorecard, where communities will be engaged to facilitate community accountability. And also we are trying very hard to move from the implementation to facilitation by encouraging the community health workers to come up with micro plans, and what if we just come in and support where need be in terms of maybe capacity building or funds. This is one way moving forward. Next. A lot of learning. One thing that we've learned is that encouraging government staff to come up with micro plans is one way of building ownership and sustainability. Because every time plans are coming for more relief, they'll take it as an external thing. So introducing micro plans, we are seeing a lot of ownership of health and nutrition interventions in the districts that we are working with. Another thing that we've learned is the use of local rapid assessments. It's quick, it's easy to interpret, and it's cheap. So the use of this has helped us to have data which the community health workers can discuss and act on, compared to using the large evaluation data. And lastly, we've also learned that engaging the sub-districts, it's fostering sharing and also a lot of learning at district level, and it's effective. Thank you.
Thanks very much, Matita. It's another exciting presentation on the value of care groups in Malawi, and very best wishes to you as you take on as country leader. We hope this will eventually be scaled up nationally and integrated into the national CHW systems. I was particularly impressed with the implementation mindset to facilitation mindset. And this is a key takeaway lesson for all of us, especially as we work with community health programs. Thanks very much. And please remember to post your questions in the chat box. Our final speaker this morning's session is Dr. Ann Peterson. Dr. Peterson began her career in global health as a missionary in Kenya and Zimbabwe. Subsequently, she consulted on neglected tropical diseases for CDC and WHO before moving into policy and political positions, first as the Health Commissioner for the state of Virginia, and then as Assistant Administrator for the Bureau for Global Health at USAID, and this was from 2001 to 2005. She oversaw all of USAID's global health programs in maternal and child health, AIDS, family planning, neglected tropical disease, health systems, and the launch of the Bush administration's PEPFAR program. She served as America's Senior Vice President for Global Programs till June of last year and is currently the president of CCIH board. So welcome, Dr. Peterson. You have the floor now.
Thank you, Anbrasi, and hello to everyone. It's really a joy to be here. We've talked about communities, we've talked about faith, we've talked about ministries of health and government. And in the global health space, the US government and USAID is a dominant force. It's a community in itself. And I just had the privilege of conducting a strategic assessment of one part of USAID's learning and found some really fascinating things that I think are applicable not just to USAID, but to the faith and CCIH community, which I'll present to you today. So next slide. We were asked to do a strategic assessment of the Research and Policy Division. It's a small group within USAID's Maternal and Child Health Nutrition Office that is supposed to be doing the meal support, the technical assistance that is doing monitoring and evaluation, knowledge management, very strong role in implementation research or implementation science, and getting involved in what they call the collaborative and learning agenda. Our purpose was to find out what this group has been doing, what their strategy was, and then make recommendations on how this Research and Policy Division can do the learning agenda in a way that improves the outcomes of the USAID missions and the maternal and child health portfolio. Next slide. So we looked, this is USAID, we looked at lots and lots of documents. It was a qualitative study. So we talked to many people, more than 76. We did an online survey of primarily the maternal child office staff that weren't part of this division. And then again, we're with USAID, so the lots of acronyms. A lot of internal players to USAID, but notably missions, the country offices in Kenya, Uganda, and Ghana, and then some of the important external players in the global voice space, I will call it, and that we did predominantly the open-ended questions that snowballed. So we have some quantitative data, but we really began with what we got from our document review, put together some questions, and then continued to learn ourselves as we went forward. Really important, I think, for this group is that many of you are experiencing co-creation with USAID. We experienced it in this project, and it had some take-home lessons itself. But we also did regular stakeholder sessions, which were really important, a monthly gathering to ground truth everything we were learning. And one of the most fascinating things I'll give you now is how quickly they took from those stakeholder discussions, action items began to work and implement them. It was all done virtually because of COVID. That did some learnings in itself, as you've heard from others, and was also a limitation for us in some ways. So next slide. We very quickly realized that while this Research and Policy Division had a mandate to support learning and what they called learning and adaptive management, not very many parts of USAID actually drew from them, or missions bought into the kinds of mechanisms that could provide it. So then the question became very quickly is, where are we on learning and adaptive management? Does anybody want to do it? And why do they do it? And then why don't they do it? And if you are doing, what are good qualities? Where do you get it? We looked at the kind of technical support areas that the Research Policy Division does, both in person and through their, quote, mechanisms. And then where should this Research and Policy Division be going? And how do you build in the externalities, things like COVID that completely change both how and perhaps what you are doing, and what do you do about that? So while this is a strategic assessment of a particular division of USAID, the main focus of the project itself and what the parts I'm going to present to you today are really around that learning and adaptive management that has implications much more broadly. Next slide. So we did frequency tables and word clouds. We did have some subgroups so we could get the viewpoints of the staff at headquarters, the ones that are external to USAID, the missions, the ones who are running these different mechanisms, like the New Momentum one. And very interestingly, and many of you have experienced it, and that is when you're talking with people about something and you start the conversation and somebody then raises a point and everyone else goes, oh, that one is really important. Because we were doing a qualitative analysis, we really wanted to try and capture that passion, not just how frequently somebody mentioned a particular area of learning, but how deeply they seem to express it. So you'll see some an attempt, a nascent attempt to visualize how we did that. And we did it from the frequency, the how they said it, and some of the quotes. We had lots of conclusions that built from across, and we did a lot of triangling across, and then ground truthed it through our stakeholder meetings. So that's methodology. Next slide. Here's what we found, that even though they weren't asking for help in learning and adaptive management, it was actually very highly valued. Everybody said on a 5-point scale, it was a 4 to 5, except for 2 people. One person said, well, maybe it's a 3 because I have other things I need to prioritize. And one person said it's a 10 on a 5-point scale. It's so important because we can't actually do anything else if we aren't learning. We put together a list of potential reasons for people to do learning and adaptive management. We started with about 13, and it rolled and increased as the conversations went on. And the top 2 were you do it because you want to increase the impact and you want to do process improvements so you do it more efficiently. Then other ones, and there was some subgroup prioritization. Leadership wanted to tell the story. They wanted to be able to take the results in a simple way and bring it to, say, Congress and get more funding. But achieving scale, identifying obstacles and opportunities, and then that mandate of this division itself, that accelerating research to use. When we began, looking at obstacles wasn't our major priority. So we only had 4 items in there. By the time we finished the project, we had more than 25 items. And the top ones were time factors and competing demands are reasons that people are not actively doing learning and adaptive management. And interestingly, mindset, meaning learning is less important than achieving results. And failure dynamics, meaning you got to keep your funding going. So you can't tell them what didn't go well, even though being clear on what didn't go well is going to be very important for both you and others to learn from your projects. And these other obstacles were strikingly higher than technical skills. We asked about technical skills and strategy and metrics, and what they gave us back were things on a much more interpersonal and time-related and priority setting. So there was some consistency across groups, but there was also some variability in the priority and passion of the valuing and the obstacles that were identified. Next slide. And here you see it really pop out in this word cloud that while we asked about technological things, they talked about failure, mindset, competing demands, silos, turf, overload, bandwidth. So very early on, we realized we were moving into a whole different realm than we thought we were going to have for this research division. Next slide. So then the question is, if people valued it but had obstacles, how do we know when we do it well? And you've heard some of these issues come up in the other discussions. Number one was the early and continuous stakeholder engagement, then joint priority setting, then being able to compare effectiveness. There were more than 20 of these. The dots on the side represent both frequency in the size on sort of a 3-point scale. And then the color represents the passion, the intensity. So the early and continuous stakeholder engagement was not only the most frequent response on what was critical, it was the one that people spoke about most passionately. Some of the other ones on building local leadership capacity, it came up later in our discussion, so it was less frequent, but the people who talked about it felt very, very strongly about it. So we've made an attempt to capture both the frequency and the passion or emotion behind that, the contributions. Next slide. We did a small survey, and this was looking not just on how to do learning and adaptive management, but when you're doing any kind of technical assistance, what are the critical attributes? Because this is a role of this department. And again, in the written survey, you can see that most of the items are very technical. Do you understand the local context? Do you have expertise? What does it cost? And the understanding of the local context comes to the top in the survey. If you go to the next slide, we again have a word map, and this is from our interviews. So it went well beyond the technical aspects that were in the survey, and you can see the local context pops again, but communication, facilitation skills, trust, respect, power dynamics. These were not things we asked about. These are what people gave us when we said what's important in how you do technical assistance. So most of the responses were in the area that we looked at and called the interpersonal skills, the how do you do it, how do you interrelate, how do you build partnerships. If you want to get to sustainability, you have to have vibrant partnerships, and all of these things are more important to them than do you know how to do the research design or your M&E skill set. Those are needed, almost taken for granted, but the attributes of good technical assistance really came out in these interpersonal skill sets. Next slide. So then we looked at, going back to our original purpose, the roles for this research department and where they should be working. And specifically, do they have a role at the global learning, global voice, the missions, or across the Bureau? And what was reaffirmed by everyone is that there is a role for a group that is involved in learning and adaptive management, not just to be doing technical assistance to one level, but it's important to be able to bring global issues to the missions and to the rest of the office. It's important to bring the field voice up into global learning. And so it was reaffirmed that this division should be working in all of these areas. Next slide. But most importantly, that there was a series of tasks that needed to be done for this learning agenda that had to do with standardization and harmonization, and that this division could play a role in making those in bringing those disciplines to those other 3 areas where they are supposed to be working. So next slide. We also asked about COVID and the impact on COVID and external things on the learning agenda. And one of the clear things that came out over and over is that if you're a good manager, you have to learn and adapt. And that making failure safe is really important if you're going to promote learning. That there are, especially within probably government systems, and I'll speak more there are cultures, systems, and personnel that are just so focused on results. USAID is responsible to Congress for achieving results, and that is wonderful, and they do a great job, and many of you get funding, but it can hinder the ability to be flexible and to respond to learning. And therefore, there needs to be both metrics, as we've discussed in sort of the spiritual realm, but also a return on investment. You know, how much learning and the cost of learning and cost of co-design and bringing in the stakeholder voice, how much does it take? And I will tell you, in the co-design we did, it took a lot, but how much does it get for you? The other is that you need to retain and sustain learning, especially across grant and leadership changes. So for USAID, they often work in 3- and 5-year timeframes, and, you know, out with the old and in with the new. And that may include all of the partnerships that have been so, you know, nurtured and brought to capacity, and then there's no follow-up on it. Go to the next slide, please. So one of the things that was very interesting is just that the learning and adaptive management, it was valued, but that we didn't have the time and room to overcome the obstacles, that there are a series of technical priorities that could help move learning and adaptive management forward simpler, faster, more efficiently. But go to the next slide, because this is probably the most important one. And that is that within learning and adaptive management, the how you do it is as important as your M&E technical skills or your data visualization, that you need to have people cross-trained, and that communication and interpersonal skills are as important as technical. Again, if you look at the data we got, there were words like listening, humbleness, giving true voice, and power to other people. And that partnerships and relationship building is an endpoint in itself if you are serious about learning. And one of the biggest messages to USAID is that they need to work on their soft skills, not just their technical skills, and build the capacity of their own missions, of the local government and their local community partners, so that those partners can continue the work themselves. Next slide. And just a couple quotes from our respondents. Most important probably is the sharing the learning so we don't make the same mistakes again and again. Next slide. Thank you.
Thanks very much, Dr. Peterson, for emphasizing the drivers of co-creation and co-design for learning and adaptive management. The measurement landscape is rapidly advancing with increasing levels of complexity and sophistication. And it seems like M&E personnel have a daunting task ahead of them, with new dimensions of climate change, faith metrics, and outcomes, and including the recent COVID disruptions. in addition to achieving the traditional metrics for the Sustainability Development Goals and universal health coverage. It makes us to pause and rethink how we do business. One of our former students at WHO has embarked into a crusade for including the compassion and empathy metric for people-centric PHC systems. So it looks like we are spearheading a dramatic new paradigm in how we measure and engage with communities and our partnerships. Three key messages that emerged from Dr. Peters' presentation for me was considering learning, that it's more important than achieving results, and making failure safe to promote learning. And I think many years ago, Dr. Mosley shared this document from the Institute of Medicine on the 7 sins and virtues of public health. And Dr. Peterson has reminded us about the value base in our frameworks and what we do about integrity and honesty and trust and compassion. So thank you very much, Dr. Peterson, and we hope that the cross-learning that you recommend and from the successes as well as failures will be a new construct and principle that we think about moving forward. This morning, we want to thank all our speakers for a very galvanizing and dynamic session, introducing us to new evidence based on faith metrics, providing us new tools, resources, and new dimensions of the theory of change modeling that we need to be considering. So thank you very much. And now we will move on to a Q&A session. And some of these questions have been posted, and we will be addressing each of these with our speakers this morning. So our first question is to Mary, and this comes from Emily on how we deliver health programming in a way that follows the core humanitarian principles, while also asking your beneficiaries about spirituality. How do you mitigate the risk of making people feel they need to fall in line with your own Christian ideals in order to be able to participate in the health programming? So over to you, Mary.
Thanks for the question. It's a great question, and it's something that we talk about a lot at Kingdom Workers. We want to make sure that we are being extremely inclusive of everyone, no matter their beliefs. And so 2 things that we do to help ensure that is, first, we're really explicit in our programming. So when we're partnering with people or working in a community, they know exactly who Kingdom Workers is, and they know that sharing our Christian faith is something that we will do. And they also know that you don't have to be a Christian to be part of it. It's just a way that we show love to other people. So just making that really explicit right at the beginning of anything that we do just helps set the stage for if we do ask a question about Christianity later, it makes them more comfortable with it. They expect it. And then the second thing that we do is we're very careful about how we ask questions. We don't put the spiritual questions at the beginning of the survey. We'll put them farther down in the survey, and we'll also only use a few of them. So I talked a bit about being really focused. We're never going to ask someone 20, 50 spiritual questions. We'll ask them just a few and put in a lot of other questions too. And then we also don't require that they answer those questions. If somebody doesn't want to talk about it or doesn't want to answer the question, we give them response options to allow them to say, I prefer not to answer, or something like that. So in those ways, we hope to make people more comfortable with the questions that we ask and also help them expect those questions.
Thanks very much, Mary. This next question is for Jennifer. I know you've already responded, but for the benefit of the rest of the audience, maybe you can clarify what the Buddhist approach is.
Yeah, thank you, Anbrasi. And thank you, I don't remember now who asked the question. I think it was Maria.
I think this was Maria.
Yeah. So the Buddhist approach that we're highlighting in the compendium is the approach of the Buddhist organization Soka Gakkai International, or SGI for short. I mentioned in my presentation that I contacted one of their members and told her about our research and said, so how do you guys do meal? And she was literally like, we don't do meal. What is meal? We don't care about meal. It actually turned out that one of the reasons why they didn't was that they relied on community funding a lot. So there was no external push to consider formalized forms of meal. And then there was a moment when we thought, okay, like we're just not going to include them in the compendium because they just don't do meal. But then it turned out that what they do is they have regular gatherings. If I remember correctly, it's every month in members' houses. So it's like a very grassroots and very localized approach that they have. And they use these meetings for worship, for formal worship. So they chant, they read the scriptures. And the third element of these meetings, which is integrated into every single meeting that they, every single of these meetings that they hold, is sharing experiences. So that's literally how they call it. It's experiences, and they share experiences. And at these meetings, people sit together, and members of the group will have prepared an experience. They will have carefully thought this through, written it up, and it's usually starts with a problem that is being described, and then they outline action that was being taken, and in the end they share the outcome. And this could be at different stages, so it could be issues people are still struggling with, or it could be problems that they have solved. And what was also really interesting, and this is in line with their approach to seeing spiritual development as important as physical development, was that they said these experiences could be anything from someone organizing a campaign to counter nuclear armament, for example, or it could be someone overcoming drug addiction. So it was not just what we would call programming, right? Like, but just different action that people have taken on different levels, which I found so interesting, because a lot of us speak about holistic approaches, but then we continue using language like programming, for example, that does divide the actions that we take into different categories, which may or may not go counter this idea of holistic approaches. So there I put the links to the compendium, which is very long. It's almost 100 pages long, into the chat. We have a summary brief, which is only 5 pages. So that's for the busy people who just can't bother going through the 100 pages. And there are also direct links to the case study, to each of the 10 case studies. And I put the one for Soka Gakkai International into the chat. Yeah, and I leave it at that because I've already spoken a lot, and there are other people on the panel too who may want to say something.
Thanks.
So over and out.
Thanks very much, Jennifer. And I'm sure we can look at those resources, especially the summary, and see how this can be integrated into contexts of different faiths. Thank you. This next question comes from Dan O'Neill, and it's directed to all the panelists. So any of you can jump in and respond. And he wants to know if we have any suggestions on influencing faith leaders to measure data and influencing development leaders to consider faith factors. So anyone can jump in and give your perspectives. Or maybe I will direct it to the trio from the field, Naomi, James, and Matilda, maybe you can reflect on it and then the others can join. What's been your experience?
Yes, I'll go ahead and maybe begin. The tools that we use are not necessarily directed to just Christian beneficiaries. They are more on indicators, project indicators, because our target is not just on the Christian community. So I wouldn't necessarily be keen on saying that our tools are directed on a Christian cohort or a Christian population.
Anyone else wants to jump in?
This is a little far afield from my particular study today, but in my role as USAID and coming out of the study is that data to tell the story. And at the sort of moving the funders and the large stakeholders, being clear what the faith community is contributing, meaning measuring the results of the programs done by the faith community and telling that story to decision makers is very powerful. And so translating what's happening in your communities, getting the meal applied to and then bringing it back up through the system in order to get the funding and attention, I think is really important. When US government administrations change, we often worry that they're going to defund faith players. But I think that as the faith community demonstrates their success in ways that are understood by those communities, they will continue to be successful.
Thanks very much, Dr. Peterson. It was Edwards Deming who said, "In God we trust and all others must bring data." So we have a big responsibility in showing and illustrating and publishing the evidence base from these faith investments and the importance of the faith metric. Our next question is for Naomi, and this is from, again, Maury Mustafa. Is it necessary to adapt the system of theory of change with regards to the RMNCH projects?
What I would say is that I think it is necessary because many times in monitoring and evaluation, and generally in just collection of strategic information, this has been looked at as a very technical aspect. And this means that data has been collected by professionals, been analyzed by professionals, and these same professionals have used this data to make decisions. But when the project exits the community, then the good findings of the project are not utilized and they're no longer relevant within the same community. For me, I think this change is necessary because there definitely is a space for inclusion of the community. And this space allows for the community members to own the process, allows for the community members to begin to utilize the information that comes out of these particular processes. So I think this data is not just technical, it's not just data for research, it's not just data to be able to say that this community is at this level, this country is at this level, but it is data that should be helping communities get empowered, make decisions, create strategies that are long lasting, not just for them, but even for future generations.
Thanks very much, Naomi. We move on to maybe a related question, and this is for Jennifer from Jonas Luthanga. I hope I pronounced your name right. What can be done so that these faiths, which is Christian, Arab, Buddhist, significantly influence economic and health empowerments in communities without religious discriminations?
I'm sorry, I didn't understand the question.
So the question relates to how we can influence the economic and health empowerment in communities without religious discrimination. How can we use faith to address the economic and health empowerment?
Yeah, that's a really good question. I think I think one very first step is being reflective and being aware of one's positionality. So one's place within communities that one works in and within wider networks. I feel this is often, we're not often as far in that area as we should be. I feel that we need this more. So people, we really need ongoing and continuous reflection on who we are in a specific context and with regards to the people that we work with. But also with regards to the wider community, because obviously a lot of these dynamics are extremely complex. And I know this is a very general comment, but I feel that it is extremely important to find ways of integrating this self-reflexivity into our work before it starts, and then while the work takes place, and then afterwards as well. And then think about, also think about not just about which communities do we work with, but also which ones do we not work with. What are minorities, what are majorities in a specific context and beyond? How does that change that over time? These are all questions that I would look at and continue asking myself. And you'll notice that I give you questions again, rather than a list of things to do. And that's because I really, really believe that context is so important when it comes to these sort of questions. So I could give you a list, but it might just not make sense in the context that you work in. So I would rather think of guiding questions and questions that can initiate and motivate reflection.
Thanks very much, Jennifer. And we will make sure we access some of the resources that you provided. Since we are almost running out of time, we have two more questions. And one is for Dr. Peterson. How do you engage in shared ownership of M&E frameworks when your partners don't see the value of good M&E work?
So I think one of the things we discovered is that if you give the time and space and then show how it will improve how their voice improves the results, then you get much better engagement. So at least within the missions, the partners on the ground in Kenya, Ghana, and others, when you gave them the space to say, here's what's important in my community, here's how you get the local contextualization, if you do it that way, it isn't going to work. If you do it this way, this is the result, and then show that it happens. We had one of our external respondents give an example, and I think it was from Nigeria, where they spent an incredible amount of time, like a whole year, in the co-design on the front end, which it's painful to go through that level of co-design. But he said that once you then did that, you had such deep buy-in by those local partners. They knew their voice and their priorities were included, that the initial phase went fine, they showed results, but then the scale up, which is one of our biggest problems in global health, you've got the proof of principle in your pilot, but getting to scale up is really hard. Well, it became much simpler because those engaged stakeholders then helped disseminate, and while the initial co-design took a year, they then in 6 months went to an extremely large population, 6 district scale up, just boom, because of the deep co-design and the results metrics that came out of it. So he was one of the ones who said, you know, yes, there's a huge upfront cost. It's worth every penny of the time and effort because of the change that it gives you in the scale up that we're struggling with so much anyway.
Thanks very much, Dr. Peterson. There is a question that is directed to all speakers on how we can adapt the meal tools, which are now explicit on Christian concepts. So how do we adapt these when working with other faith communities?
I'll jump in because my assessment was with a secular audience, and I think this applies to Christian and other faith. If you build in the principles of listening to your stakeholders and make that very clear, then all faiths will feel like they are heard and are contributing.
I could just add a little that, like for the case of SCOPE, we have a curriculum which is called Making Our Communities Better. It's basically like an induction for the faith actors across both the Christians, Muslims, and all that. It's basically aimed at creating awareness among the faith leaders so that they become ambassadors of change in the communities that they live in, of course, with a bias towards health. But it also has a component of just being aware of what's happening in the community. And so that's a good way of introducing meal. May not be very structured, but a good starting point so that going forward, then they can be cognizant of the fact that they need to be monitoring and observing and learning from what's happening within the community to have informed decisions in matters that affect them within their communities. Thank you.
Thanks very much, Dr. Peterson and James, for those observations. And I think this next question ties in to what was discussed previously. So this is for Matilda. Does partnering with government agencies enhance or prevent a more active local participation?
Yeah, partnering with government enables the communities to engage more with the government counterparts because, you know, our government workers, they are permanent. In most of our community health workers, they reside in the community and they already have that trust and a strong relationship with the communities compared to World Relief staff. So partnering with government already, community already, they look at the community health workers under government as people they can trust, and it's easy for them to follow up anything that is being promoted. The uptake of the interventions is far much better when the government is in the forefront implementing whatever we are doing, and World Relief, we are only in the facilitation mode. We are at the back seat. Yes.
Thanks very much, Matilda. And I think there was another question for you on microplans and local rapid assessments and how these are communicated to stakeholders. And this is again from Dan O'Neill.
Mm-hmm. Okay, when we conduct the local rapid assessments, I indicated that these are done on quarterly basis, and the data can be analyzed at local level, locally, so that communities and the community health workers can use the results. And it can also be analyzed at a district level. And the results are shared with stakeholders at all levels. Like at community level, we have different stakeholders working in nutrition. As I indicated that this is an integrated project. So as they are meeting at community level, they share results. At district level, the same thing. They normally have monthly meetings, quarterly meetings. They will also analyze the data and share the results. The same if there are issues. The results are again shared at national level when they are having the Sun Learning Forum. There are also issues that are presented by district nutrition focal persons. They present to the director of nutrition. So in all these forums, the results are discussed, lessons are learned, and plans are formulated. And government is acting on these issues at levels, not just at district or national level. Thank you.
Thanks very much. This final question is directed to James. We've just followed your presentations on religion and spirituality, which appear complex. Would you like to tell us how you have implemented these notions in the communities to meet their social, economic, and spiritual needs in a practical way? And how can you tell us about the impact or success stories of this Christian influence in working with poor people? That's a loaded question, James, so you can pick any aspect of it that you want to respond to. But it's the most critical aspect of our learning in this session.
Yeah, so as I shared, we're working with all faith, but I think when you talk about religious groupings in Kenya, you're largely talking about Christians and Muslims. The other religions are very, very minimal. Islam is more predominant along the Indian coast and then northeastern, but for the areas that we work in, it's not that much. So by default, we're working largely with the churches more than the mosques, as you saw in my presentation. Originally, World Relief works with communities through churches, and they organize churches through structure they call church empowerment zones. And under that, there is church network committees, which are much smaller structures than the church empowerment zone. Because scope cuts across all the faith, we had to include the other faiths, which is largely the Muslims, and that's why now we call them the faith network committees. It's not been very easy, but it took time. We started by having faith summits, first of all, to discuss the project and the goals and the roles of the faith actors in that project. And after that, created the faith network committees in the local areas. It is not so easy given that there are two different faiths, and then Christians are predominant. I think if you go to any faith network, you will probably get over 90% are Christians. So at the very start, there is that hesitancy and suspicions, but with repeated routine review meetings, and of course, starting with the making our communities better curriculum, you realize that it starts getting warmer, the relationship across the two faiths start getting warmer. And especially when now they go into the community and start having some small startup projects to improve the health within their communities. So we've been doing this for around now 1 year, or around 8 months to be exact. It will be interesting to review probably at the top of 12 months and see how it goes. But the solution here is more collaborative and seeking a unity and non-judgmental approach so that we don't have conflicts within the faith networks. Thank you.
Thanks very much, James. And I think that concludes our session for today, unless anyone has any thoughts that they'd like to share from the panel. Any closing thoughts?
A big thank you to the organizing team. I've attended and spoken at so many conferences, but the organization at this conference was literally another level. So thank you so much, everyone. On the panel now, in the audience, but also behind the scenes, who have been pulling strings to make this happen.
And I'm sure all of us concur to the excellent organization by Doug and Mona and the entire CCIH leadership. Thanks very much. And to the very distinguished expert panel, we've learned a lot today about new ways of thinking, new paradigms, new metrics, and most of all, how to make a spiritual impact for God in this world and for the communities we serve. And to the wonderful audience for your questions and for your thought-provoking responses. We're looking forward to more sessions and engaging with you in the future. God bless you all, and good luck with your new engagements and work. Thank you very much.
Thanks very